concerns you may have. So let me introduce today's speaker. So Dr. Rebecca Hahn is Professor of Medicine at Columbia University, Irving Medical Center in New York, and Chief Scientific Officer at the EchoCore Lab at the Cardiovascular Research Foundation. It is our honor and pleasure at ASE to welcome Dr. Rebecca Hahn.
Hi, everyone. Thanks for joining us today. It's really my great pleasure to speak about the guidelines, which was just published. And you can see here a link to the free PDF care of the American Society of Echo. And so I know it says 178 slides. We will not be going through 178 slides. We'll get through maybe 70 or so. And I hope to be able to answer questions, some of them live. So if they're relevant to the slides that I'm presenting, I will try to answer those questions. So please enter the questions into the Q&A portion of your Zoom. And I have it open right now on my screen as well, and I'll hope to answer them. These are my disclosures. The learning objectives today are to review the justification for the new guidelines and appreciate the additional imaging components to a comprehensive imaging protocol prior to structural heart intervention. We are not going to review at this time, nor does the guideline review actual procedures. We will also review the anatomy of the aortic and mitral valves in this particular webinar, and hope to understand the essential imaging and hemodynamic assessment required as part of that comprehensive evaluation. The justification of the new guidelines comes as we have an incredibly rapid growth of transcatheter devices for structural heart interventions. And multiple societies now clearly recognize that interventional echocardiography is a subspecialty of echocardiography. The interventional imaging has been included in the ACC Advanced Training Statement for Echocardiography, where Susan Wiggers was the first author just 2 years ago. The ACC guidelines refer to the structural imager as an integral part of the heart team. And finally, the American Society of Echocardiography recently convened an interventional echo training task force to develop a training document specific to this subspecialty. So we know for sure, and I think most of us that are on this webinar now agree that interventional imaging is indeed a subspecialty for us. And the guidelines, however, are not intended just for that group of imagers that are doing procedures, but is really intended for the pre-procedural assessment and therefore level 2 trained echocardiographers, because it is indeed standard practice for those echocardiographers to obtain the TEEs prior to being the patients being considered for interventions. And without this pre-procedural screening echo, the patients cannot move forward. And therefore, the level 2 trained echocardiographer becomes an essential part of the heart team. So the purpose of the current document is therefore to provide a reference guideline focused on the acquisition of essential images that will be required for us to determine the mechanism of the structure or valvular dysfunction, the anatomic as well as the hemodynamic severity of the disease, and the specific anatomic features that may allow us to appropriately choose the device for those patients. The way that we developed the guideline was to be used in 3 different ways. First is a reference document for imaging cardiac anatomy. And so you'll see a lot of 3-dimensional imaging, but also multimodality imaging in an attempt to clarify the 3-dimensional structures that all of us have to image. And then it's designed also as a training document for image acquisition. So the text describes the actual manipulation of the TEE probe and how to acquire each of those images. And then finally, it's a guide to the comprehensive assessment of cardiac structures during image acquisition. So while you're actually doing the TEE, the tables that we developed were an attempt to enable a rapid look at the imaging levels and image acquisition that you might need. And those are divided into planar or 2D, volumetric or 3D, and functional imaging. So the new guidelines also reiterate what was in the prior guidelines. So there are 5 probe manipulations, and we don't cover very much of that in the new guidelines. There are 5 advanced 2D and 3D modalities that we end up using throughout the imaging protocols. And there are now 5 levels of imaging. So there used to be 4. And the deep esophageal image level of imaging is now the newest image level that we've added. Now, the controls of the probe include the flexion controls, and I'm just showing you here the various, what it looks like on fluoroscopy and how these various manipulations can generate images that will allow us to evaluate all the structures of the heart. And so one has to remember to use both the anteflexion, retroflexion, so typically the large wheel, and then also the lateral flexion, so left and right flexion, which is the small wheel. These become absolutely essential to the acquisition of the images. And then we have to understand the strengths and limitations of three-dimensional imaging. And so this is one of the figures from the new guideline that shows that despite the fact that we have atrial fibrillation in this patient, that we're trying to assess a systolic time interval, and those systolic time intervals remain relatively constant. That's just the way cardiac physiology is. And therefore, we should be able to acquire multi-beat acquisitions, either 2D or regular non-color images, either color or non-color three-dimensional images in order to assess systolic jets. So just a reminder of that. And then remember that there are all sorts of ways of displaying the three-dimensional imaging. Simultaneous multiplane is indeed a three-dimensional function. You cannot do that without a three-dimensional probe. But remember that one of the main things we like to do is to look at the rendered image, since it gives us a much more rapid assessment of anatomy compared to trying to integrate multiple two-dimensional imaging planes. Three-dimensional imaging, obviously extraordinarily important for the quantitation of valvular heart disease, which we'll discuss as we move forward. I don't want anyone to forget the original guidelines. This is from 2013, the poster that was generated with the 28 images that were recommended in the comprehensive TE exam of 2013. And then we've added the new imaging level, and therefore 2 new imaging parameters that you should be acquiring, particularly when you're assessing the tricuspid valve. And so the deep esophageal level is, again, the newest level of the guideline. And it was in particular useful for assessing structures that are very close to the diaphragm. And that happens to be the tricuspid valve, but also right atrium, basal, RV, et cetera. So we're going to go ahead and start this webinar with aortic valve anatomy and imaging, and then move on to mitral valve. And I want to just start by looking at anatomy and trying to make sure we all are on the same page. So when you look at the splayed open aortic root, you really understand that the aortic valve cusps are a semilunar structure, and so that they attach in a semilunar fashion, which then creates these interleaflet trigones or triangles that don't have leaflet in them. So those are interleaflet, meaning they're between the leaflets. Now, the annulus is designated as the lowest hinge point of the cusps, but that means that greater than 90% of the annulus is actually virtual because it's composed of the base of these interleaflet trigones. And so therefore, we'll show you where to measure the annulus and how it can be somewhat difficult because it's a trileaflet valve. And so we'll be in a trigone on one side and a leaflet on the other. Now, although, again, the aortic valve is trileaflet, the leaflets are not all of the same size. Typically, the left coronary cusp is actually the smallest. And that's also designed based on the curvature of the aorta. But we'll talk about all of that. But just to remember again, and this is a figure 5 from the document, showing again how it's a semilunar attachment of the leaflets. The annulus is virtual, and the cusps are designated by obviously their location, but also the coronary arteries that arise from them. So left coronary cusp has the left coronary artery, right coronary cusp has the right coronary artery, and obviously the non-coronary cusp always faces the interatrial septum. Now, when we're looking at leaflet morphology, it's really important for us in the interventional sphere to understand whether or not you have a bicuspid or a trileaflet valve. So all the randomized trials have been limited to trileaflet aortic valves, with a lot of registries now being used to document the outcomes of bicuspid. But my favorite way of determining whether or not you have tri or bicuspid valve is to look at the color Doppler. So once you get your short axis view lined up with what you believe are the tips of the leaflets, you throw on the color Doppler and you can now see color Doppler down the 3 commissures for a Trileaflet valve and only 2 commissures for a bicuspid valve. Now, sometimes these are functional bicuspid, meaning they started off as Trileaflet, but they are now only 2 leaflets with fusion of in this case, the right and the left coronary cusps. Now, when you're looking at the aortic root and ascending aorta, most commonly, our guidelines have suggested that we use 2-dimensional imaging, but aligning obviously the maximum dimension or diameter of the aorta in the screen that you're going to be measuring, and then the aorta is measured obviously leading edge. Now that's not what we do for annulus. Annulus is going to be measured from the inner to the inner edge, and the reason why it becomes difficult is that it's a trileaflet structure, and therefore when we actually bisect the maximum dimension of the aortic root, you're going to have the right coronary cusp. In this case, in the far field. So in a transthoracic, it's in the near field. On a TEE, it's in the far field. So just like this 3-dimensional image is showing you. And then opposite it is going to be the commissure. So in a trileaflet valve, again, the optimal appearance of the valve when you are maximally bisecting the diameter of the aorta is that you're only going to see one cusp. On the opposite side in systole, it's going to look very fuzzy. You're going to be in that interleaflet trigone. Sometimes you'll see some parts of the leaflet, but you're not going to see a nice clean leaflet. And what we used to teach you was to try and center 2 leaflets in the middle of the aorta in order to measure it. But we know that that's absolutely not correct now, given the fact that it is, again, a trileaflet valve. So the aortic measurements can be done in, annular measurements can be done in a number of different ways. We pioneered the off-label use of the mitral valve package in order to not have to planimeter directly down onto the annular plane. So that's called indirect planimetry. And we cover all of that in the guidelines. But there's also direct planimetry. So if you want, you can just go ahead and line up the annular plane. Again, you have to use the short axis to make sure that you're at the level of the 3 hinge points of the leaflets, and then you can directly planimeter if you think you can see the annular tissue well enough, remembering that it's virtual, so it can be kind of tough. There are automated packages of a number of from a number of different vendors, obviously not as well validated as either the direct or the indirect planimetry. The other thing that we really need to know is the coronary arteries. We don't expect all echocardiographers to do this measurement, but once you acquire a nice 3D volume set of just the aortic root, we should be able to measure the coronary height. So this is obviously to the LAD, where there's a bifurcation you see of the left main, where you could see the bifurcation to the LAD and circ, and then the length of the left coronary cusp. And any discordance there is going to be a high risk for obstruction, and we treat those very differently. And so the guidelines go over how you would then align yourself to get an image of the left coronary cusp, which is in the coronal plane for us. So you can't really get the left coronary cusp without using 3-dimensional imaging, and then how to measure both the cusp length and the coronary height. Now, when we're assessing aortic stenosis, as well as regurgitation, and frankly, almost all valvular heart disease, we're going to need to have the LV stroke volume. And so in order to obtain the LV stroke volume, we need to use 2 of the gastric views, the deep transgastric. So this is all the way down, looking up at the aortic valve as if you were in an apical view for a transthoracic, right? So the TEE probe is all the way down toward the apex, and it's looking up at the valve. And then the more shallow transgastric view. And this puts you basically, if you think of it as initially just a 2-chamber view, but then you further rotate to get yourself a 3-chamber view, then you can also get the aorta. Now, they give you slightly different numbers, and this is really super important to remember that the deep transgastric view, once you've aligned it, it's going to really look straight down the barrel of the aorta. And therefore, it's a perfect view for acquiring the pulsed Doppler, either if it's a stenotic or regurgitant or normal valve, as well as the continuous wave Doppler. When you're in the transgastric view and you're a little bit shallower, the aorta now falls off to the right side of the screen, which means that your CW Doppler is actually going to come across the aortic valve, but be facing a little bit more toward the right heart. And this is what we consider, at least I call, it's not in the guidelines called this, but I call it the equivalent of the right peristernal view. So remember that for aortic stenosis, 50% of patients are going to have a higher velocity from a right peristernal view, just because of the typically the septal bulge and the direction of flow has been altered in the elderly patients. And therefore, we would always recommend you attempt to get these Dopplers, particularly for aortic stenosis, from both a deep transgastric and a transgastric view. Don't forget to put in questions if you want. I'm monitoring the Q&A as well. I don't see any questions, so I'm going to just keep moving here. Let's talk a little bit about aortic regurgitation morphology. In the guidelines, we outline, and this is from the guidelines on regurgitation, we outline the various types of aortic regurgitation as type 1, which is normal cusp motion with aortic dilatation or cusp perforation. So the motion itself is normal. This is similar to the Carpentier for leaflet mobility for the mitral valve. And then type 2 is cusp prolapse, so excessive motion. And then cusp 3 is restrictive. So just a combination, as in the case that I'm showing you right here, it's a combination of aortic regurg and aortic stenosis. But one of the most common etiologies of aortic regurgitation is prolapse of the leaflet. And so this is indeed prolapsing right coronary cusp. And you can see in that setting, there is a posteriorly directed jet because of the prolapse. So just like mitral prolapse, this is aortic leaflet prolapse. And because of that, one has to remember that the direction of the jet is now toward your transducer. And so you've actually lined up perfectly in a long axis midesophageal view with the regurgitant jet direction, and therefore you should do your Doppler here. So in this particular case, we've gone ahead and thrown the CW across to get the diastolic spectral profile, which you can then obviously perform the PISA from. And then because again, that we're lined up so beautifully with the insonation beam, we've gone ahead and baseline shifted to get the proximal ice velocity surface area. So comments on the optimal way to measure alveolar tract velocity. I'm going to go ahead and save that for later because we're going to cover that in just a second. Now, there's another question. Could you comment on contrast utility? I do not use contrast. So contrast, because of the noise that's generated by the bubbles, and we've all seen that noise, right? I think it overestimates the velocity profile, and I think it's our job to basically try and just get aligned with the jet and not use contrast. That's my personal view. Others may think differently, but remember, there's a lot of and we've looked this up because in the core lab we were curious. We were asked whether or not they could use contrast, and the bottom line is that there's so much acoustic enhancement that some of it is not actually real flow, and so we in the core lab have decided never to do that. But I welcome anyone else's, and I think my co-authors may also be here, and we can ask them at the end of this lecture as well. So don't forget that if you have a central jet, not an eccentric jet, but one that's coming straight down the middle, then the gastric views are going to be the ones that you want. So this is deep transgastric to, again, get the proximal ice velocity surface area. We've baseline shifted. We've gone ahead and gotten the pulse wave sample volume. And then also, because we're so well aligned, we can also measure the CW, and in this case, looked at the pressure halftime. Remember also that from either the descending, proximal descending, or the distal descending aorta, you want to go ahead and look for flow reversal. So holodiastolic flow reversal. And in the proximal aorta, we really want to have an end diastolic velocity of over 20 centimeters per second in order to be specific for severe aortic regurgitation. Now, so we'll talk a little bit about the placement of the sample volume, and this is where I'll talk a little bit about flow acceleration. But this patient obviously doesn't have any subvalvular flow acceleration, but there's going to be flow acceleration at the level of the valve because, again, we're approaching a stenotic orifice. And so when you approach a stenotic orifice for aortic stenosis, you actually want to go ahead and be just proximal to the flow convergence. So I don't show it to you on this slide, but indeed, we'll turn the color Doppler on and then set our sample volume just above apical to the flow convergence. And that allows us to measure the modal velocity. So you're trying to measure the non-spectral broadened PW profile. So that's this one to the right-hand side of the moving image. And so you can see that a modal velocity means you've got almost laminar flow and almost all the blood cells are traveling at one speed. That's why you're dark on them inside the spectral profile, and you've got this nice bright and well-defined white line, which is all the blood cells traveling at one speed. And that's what you want for aortic stenosis. Now, if you don't have aortic stenosis, you have aortic regurgitation. Then, and if you don't have aortic regurgitation, you just have a normal valve, then you want to be on top of the annulus when in systole. So remember that you have longitudinal shortening, so that from a gastric view, the annular plane is going to move toward the transducer. So it's going to move up. Therefore, we tend to start a little bit lower apical to the annular plane. And then in systole, we want to make sure that the sample volume crosses the valve, which means that you're going to have a closure click. So look at the lower left corner. You're going to have the closure click without an opening click, because remember, you're going to have started apical to the valve, but you're going to cross the valve in systole, and therefore the leaflet will close and give you a closing click without an opening click. And that's the most appropriate spectral position of the sample volume in patients who have non-stenotic valves. Now, in the setting of aortic regurgitation, obviously you may actually see the aortic regurgitation. So a little tough to know precisely, but you can really see how beautifully laminar the last figure on the lower right-hand side is. And that, again, is an appropriate position of the Doppler for aortic regurgitation. Now, if you have flow acceleration because of HOCM and systolic anterior motion or a hyperdynamic LV, now all of a sudden it's much more difficult because you've got acceleration of flow that you can't account for. And so sometimes what we'll do, and this is just my opinion, we did not add this to the guideline, is that I'll use an RVOT stroke volume. And so one of the reasons why the RVOT stroke volumes become so important is that we may have to use them as the forward stroke volume for many of our calculations. So if you have aortic regurg and mitral regurgitation, then you're going to need a valve that doesn't have a lot of regurgitation, and the pulmonic valve frequently has just trace or trivial pulmonic regurgitation. Then you're going to have to use that as your forward stroke volume and subtract the other stroke volumes from it in order subtract it from the other stroke volumes in order to get the regurgitant volume. So RVOT stroke volume for us, very, very important. Please try to give us some views where we can measure the diameter of the RV outflow tract, again, at the annulus. And then can also, we would ask for a Doppler. And again, same thing here. You want to be typically just apical to the annular plane of the pulmonic valve in diastole, and then have it cross during systole. So you can see here, you can either use a view that's the RV basal view. So this is about a 30 to 60 degree rotation, or at a 0 degree rotation for the RV inflow outflow view. And this is with a right lateral flex and an anti-flex to give you that RV inflow outflow view. Now, there's a question, TE for stroke volume should be done routinely. Absolutely routinely. We're going to need it. This is, again, the pre-procedural TEE for consideration of a structural intervention. Now, I'm not saying that you need a stroke volume for every routine TEE, but every TEE in a patient who has valvular heart disease, in which you are going to consider that patient for an intervention, we need to be able to quantify that valvular heart disease. And in order to do that, we need to have the stroke volumes. Okay, so just to digress for 30 seconds, because we will not be covering pulmonic valve imaging in any of the other webinars. There are multiple different views that you can get the pulmonic valve in. And particularly if you have a prosthetic pulmonic valve, or you have to do a valve in conduit type of thing, then you need to be able to get these high upper esophageal views, as well as midesophageal views and transgastric views. It's pretty hard to get, obviously, a good 3D of these are all Roberto Lang's images. So pretty hard to get these 3D images are Roberto's. I've not been able to get an image like that, but you know, you can certainly, if you've got really pristine images like this, can get three-dimensional imaging as well of the pulmonic. Okay, so I'm going to move on to mitral valve imaging unless there's other questions, which I don't really see any right now. So we'll move on to mitral valve, and we're about halfway through, so I think it's pretty good timing. Again, happy to answer questions as we go along. So let's just review the anatomy of the mitral valve for just a second. This is one of the figures, obviously, in our guideline, and you can see that the mitral annulus in panel A is somewhat D-shaped, and the scallops of the posterior leaflet are the most clearly defined. And there aren't really scallops of the anterior leaflet, but the opposing anterior leaflet we label the same as the posterior. So that's why we have on the one side, which is lateral, A1, P1, in the mid is A2, P2, and then in the medial side is A3, P3. Now, remember, for the mitral valve, the little red dotted line is at the hinge point of the leaflet. And the hinge point of the leaflet is not at the aortic annular level. The hinge point of the mitral valve is further down the leaflet, and the space between the hinge of the leaflet and the annular plane of the aortic valve is called the mitral aortic curtain. And so again, that hinge point is indicated both in B and C. And then the bottom images are just to show you the complex nature of the papillary muscles and chordal apparatus, remembering that the compacted portion of the myocardium is where the endocardium of the LV is, and the papillary muscles should never be included when you're assessing LV size and function. There was another comment here: if good PW, RVOT, or LVOT data cannot be obtained, should it be done by TTE immediately after the TE imaging? What a great question. We always do that. If we've had any trouble, then that we're going to have a stroke volume, then absolutely, thank you so much for asking that question. Use your transthoracic. Use your transthoracic. It gives you a slightly different imaging plane. Remember, we're tied to the esophagus. There's nothing I can do about where the esophagus is. Obviously, we try by using the flexion wheels. But sometimes it's just not possible, as you've intimated, that you know, we just can't get to it. So absolutely, we've got a transthoracic probe with us, and we go ahead and get the PW of the RVOT and typically the LVOT from the transthoracic. Okay, I'm going to keep going with the mitral annulus. On the CT, you can see here that in reality, the mitral annulus is the saddle shape, and the horn is the aortic mitral curtain. But as we just discussed, most commonly, and when we're, for instance, calculating stroke volume across the mitral valve, we are not going to include the horn. And we're just going to go from trigone to trigone and cut that off and make it a D shape. And that's just the standard of CT imaging right now when we're looking for transcatheter devices, particularly transcatheter mitral valve replacement devices, but also what we're going to do when we're calculating the stroke volume across the mitral valve. So remember, I'm just going to digress for 10 seconds. When you're calculating the stroke volume across something, you're going to have an area and then you're going to multiply it by the distance that the blood travels across that area. And therefore, the area is going to be a planar, what we use is going to be a planar structure. And we're going to have typically a circle, or it could be an oval, whatever three-dimensionally, you can also trace it, but it's going to be planar, because then you're going to put the sample volume at the same level that you measured, and you're going to get the velocity time integral at that location. And the velocity time integral in meters or centimeters is the distance that the column of blood moved in a single beat. So now you got the volume, the stroke volume, right? So you got area times distance equals volume. And that's why we use planar structures in order to calculate the area. Okay, so let's move on a little bit to morphology, because, I'm sure you've heard a lot about Carpentier's leaflet mobility classification. And, this was all a surgical classification, but we've adopted it, and that's fine. I personally am not sure of its clinical utility, but we have classified indeed all these abnormalities based on the type of movement. And so type 1 is, we'll go through them. So why don't we go through them one by one? So type 1 is normal leaflet motion. And in this particular case, you can have normal leaflet motion, but you've got a really dilated annulus. Now, there's a lot of other type 1s, right? If you have a perforation, that's a type 1 because the leaflet motion is completely normal, but you've got a hole in it. So therefore you got regurgitation. But this is the classic thing that we're worried about, which is the atrial functional mitral regurgitation. We're going to cover that again in just another second. But this is where the annulus has become dilated because it's followed the dilatation of the left atrium. And now you just don't have enough leaflet to cover the annular area. Type 2 is excessive motion of the margin of the leaflet segment above the annular plane, so atrial to the annular plane, and that's your classic prolapse. And there's lots of different grades of prolapse and progression of the disease, from fibroelastic deficiency, or FED, which ends up occurring in the elderly and a little bit later in life, to the Barlow's, or the really, really myxomatous disease, which tends to occur in younger patients. But obviously FED with myxomatous changes, Barlow or form-Frust Barlow's, and mitral annular disjunction are all along a spectrum of the type 2 diseases where you have excessive motion. Now, type 3A is restricted, sorry about the typo, restricted leaflet motion during systole and diastole. And so these are your classic rheumatics. But it could be carcinoid. If you had left-sided carcinoid, obviously you can have that on the tricuspid valve, carcinoid disease, or other infiltrative process. Radiation fibrosis can sometimes give you restriction in systole and diastole as well. So that's type 3A. 3B is restricted leaflet motion predominantly during systole. So now they open normally. So these are really nice. They open really normally. You got these big valve areas. If you were to planimeter the valve area, some of these are, 8 and 9 centimeters square. They're really, really big, but they cannot close at the annular plane. They are now, because they're being tethered by apical displacement of the papillary muscles or lateral displacement of the papillary muscles, you now have the leaflet closure occurring in the ventricle. So apical to the annular plane, and the ventricle is obviously going to be much bigger than the annulus, and now you don't have enough leaflet to cover the to cover that area, and that gives you ventricular functional regurgitation. So the other classification that we use is primary and secondary. So Yasser has asked, can you please elaborate on how to differentiate between normal scallops versus cleft-like indentations and clefts? I may show you a cleft, so I'm going to save that, but just remind me if I don't. So primary disease, obviously you see the whole list of primary disease, and primary disease can be Carpentier 1, 2, or 3. 3A, not 3B. And you can see here examples of normal leaflet motion with a perforation, excessive leaflet motion with prolapse, and then restricted in the setting of rheumatic disease. And so these are all examples of type 1, type 2, and type 3 that would be typically considered primary disease. Now, secondary disease, and this is a chart, both the former chart and this one are in the guidelines. This is secondary, and secondary, as you now know, we divide into atrial functional, which we discussed before, where the leaflets obviously close at the annular plane or just apical to it, and then ventricular functional, where they're closing very apical to the annular plane, and therefore have a tenting area, a tenting volume. And the two different types of 3B are going to be the non-ischemic and the ischemic MR. And not infrequently, the non-ischemics will have a much more symmetric looking regurgitant orifice. In this particular case, all along the commissural line. That's why it looks like you've got three different jets. It's one big jet going all across the commissural line. And then for the ischemic, which is on the far right, you can see already the infarct in the inferior and infralateral wall, causing localized tethering, typically because of the posterior medial papillary muscle being pulled away. And that gives you sometimes regurgitation that is more prominent on the medial side. Now, when we talk about why we need to look at primary versus secondary, it's because our guidelines tell us that we have to. I mean, we're going to treat these patients differently, and therefore the guidelines will allow us to use transcatheter devices in high-risk primary disease patients, assuming that they have favorable anatomy. And frankly, if they're not high risk, then those patients should be referred to surgery. And then in the patients with secondary disease, they have to fulfill the COAPT criteria, but we have to know that they're secondary, right? They have to be functional mitral regurgitation. And then they should fulfill the COAPT entry criteria in order to, again, qualify for a class 2A recommendation for transcatheter edge-to-edge repair. Okay, so in the guidelines, this is one of the figures from the guidelines we give you again, and we didn't want to reiterate our beautiful regurgitation guidelines from 2017, but this figure we thought was appropriate to remind everyone that when you're looking at mitral regurgitation or aortic regurgitation, any regurgitation, that one should remember to baseline shift. It's a very simple thing to do. It tends to be easy to perform. It does have some problems with error because, again, what we're looking for is the radius to the vena contracta, so the narrowest portion of the jet. You don't have to turn the color on and off. You don't have to. You're looking for the narrowest portion of the jet because the vena contracta can be actually distal to the anatomic orifice. It could be after the anatomic orifice, and therefore you don't want to limit yourself by turning on and off color and saying, oh, the tips of the leaflets are way down here, I'm going to measure the radius at 0.5, when in fact the radius of the piece is 1. And so we tend not to turn the color on and off. We're looking for the vena contracta of the baseline shifted color flow Doppler. Now, for quantitation of mitral regurgitation using what I call quantitative Doppler, or the continuity method, is really that we're going to be calculating the diastolic stroke volume across the mitral valve and then subtracting some forward flow. So we already discussed that it could be aortic, it could be LV outflow tract, or it could be RV outflow tract. But in order to calculate the diastolic stroke volume, we want to measure the annular area. Now, it seems silly that it's a complex structure, right? That we're using a 4-chamber view, but we have validated the use of an on-axis 4-chamber view. On-axis means there is no aortic valve seen, and that you see the two, the anterior and the posterior leaflets well defined. You're not closing them down. You're not looking at, funny commissures. And so when you have an on-axis 4-chamber view with no aortic valve in view, then what you're looking at is basically then going to be a rough average of the minimum, which is your AP view, or your long axis view, and the commissure to commissure view. And so because the 4-chamber view is this red line, it works really, really well. And this was the validation by Aichi Hyodo so many years ago now, and was advocated by Dr. Quinones many, many years before this. But it works. So it's a single dimension, a on-axis 4-chamber. Otherwise, we love to just planimeter the 3D annular area. I think that's our favorite. Okay, so now how do you get a good midesophageal view? So I guess it turns out I didn't talk about clefts, so I'm going to break for just a second and talk about clefts. So what we tend to do is we tend to look at, maybe I have it in the next. So we tend to, the clefts are here, but we tend to look at both the atrial side and the ventricular side. And so when you're looking at the ventricular side, you will see this tremendous dropout all the way down to the annulus. That to me is a cleft. Now, have I been fooled? Many times. So a surgeon will say, yeah, that wasn't a real cleft. It was a really deep fold. And sometimes we're going to be fooled. But my general rule is that if I see it going all the way down to the annulus, I'm going to call it a cleft. There are studies that suggest that, does it really make a difference? So for both the tricuspid side and the mitral side, it's unclear whether for structuralists, for interventions, whether it makes a difference that it's a deep fold or a cleft. Because it's very difficult to get your TEER device, your transcatheter edge-to-edge repair arm, to close off something that's deep. You can't actually grab anything there. So functionally, it might not make a huge amount of difference, except that what we've seen is that if it's a real cleft and you clip close right next to the cleft, you can actually widen the cleft and obviously make the mitral regurgitation less. So those are, the main ways that I have of looking at clefts. All right, so let's go back to here and talk about midesophageal imaging. So I just wanted to show you this is a CMR of a 4-chamber view, and the esophagus is way back here. And so if you use because the esophagus 9 times out of 10 is going to come down on the lateral side of your left atrium, then using the lateral flexion wheel and moving it to the right will obviously put the probe over the dome of the left atrium. That's going to be your best shot at getting on axis to the mitral valve. Now, the other thing is that when you're looking at bringing the probe straight down. So let's assume we've already gone to the right. Then the first thing that you end up seeing typically when you put your probe down is going to be some aortic valve. And so by just retroflexing from here, which is what we did in this image, then you will get yourself to the apex of the LV. So just by retroflexing. So our favorite thing to do is the minute we get in there, we get ourselves to about this level. We don't push in any further. You don't want to see coronary sinus. We may not see, from this view, left atrial appendage, but you probably will see some of the aorta. And then from there, we go to the right with our small flexion wheel, and we retroflex, and then we get ourselves lined up perfectly with the Doppler. Now, I'm sorry, with the apical long axis view. Now, the midesophageal views, this is one of those tables that we've given you, looking at all the images that could be acquired and should be acquired from the apical view. And this happens to be from the apical 4-chamber view. But then we move on to the other imaging planes, so both a commissural view and then the long axis view, to show you what's possible. Again, I already showed you this, but the procedural imaging or pre-procedural imaging and imaging assessment of the mitral valve should include these kinds of assessment, at least these views, because we can always do the measurements offline. You don't have to do them while you're doing the procedure. But these are the types of measurements that we're looking for. We're looking for leaflet lengths. We're looking for the C-sept, so the distance of the septum to the closure line of the anterior leaflet. We're looking for tenting heights, we may look for tenting area or tenting volumes. We're looking for the angle of the tethered posterior leaflet. These are all things that are important for recurrence of disease and therefore may direct us as to a more appropriate therapy. Now, from the inflow-outflow view, our favorite thing to do is do a sweep. So these are two images of us just sweeping across. And remember, these are all digital machines. And so we should be able to just, as you're moving the trackball, the machines stop storing. So what we do is we go ahead and move the trackball, and then we freeze and we just scroll back and capture the stored digital image. This is a retrospective capture. And that allows us to then just do these continuous sweeps and get a really good sense of what's going on across the plane of the coaptation zone. Wow, there is a long question in here. I'm going to have to wait for a second and just keep going for just a second. Let me finish my thought on the mitral here. So three-dimensional imaging, I just want to digress for a second, because from that commissural view, which tends to be our home view for transcatheter edge-to-edge repair, it's a great view to acquire your three-dimensional images on. But remember that this is a biplane where you have now medial and lateral, and then posterior and anterior going across. So this is commissural view, long axis view. The orthogonal view to the commissural is the long axis view. And then when you generate your 3D, which is going to be these trapezoids, now we have, and we turn it on FASE, the view that you actually have is this one, where the aortic valve is at 6 o'clock. It's not going to be at 12 o'clock. And some people will continue to use this view. Many interventionalists like this view. They don't get confused as to where medial and lateral is because it correlates with the 2D. They see the aorta, so they know where posterior and anterior are. And obviously the mitral valve is asymmetric, so you should know where an anterior leaflet is and a posterior leaflet is. But obviously, most of us have taken on the surgical view as our primary home view for the three-dimensional REM image. And that means that we're rotating it, in this instance, 90 degrees. But I just want to show you, I'll digress for a second. Let me just go over this for a second. So when you're going from 0 to 45 to 90 mechanically, so these are mechanical rotations within the housing of the probe, then you're basically, when you're looking on FASE to the mitral valve, if you're looking at the probe, that's going from 0 to 180, which is why the little indicator on your probe says 0 to 180, because it's as if you're looking at the probe, but we're not looking at the probe. We're looking behind the probe because we're looking at the image that the probe is generated. And so therefore, it's actually that we're rotating the other way around, right? Because we're behind the probe. So that when you're going from 0 to 45 to 90 to 135, you're rotating this way around the anatomic structure. Now, just remember that I would say at least 80% of the time, maybe more, our initial view has the aorta in it. And so when we actually have the aorta in it at 0 degrees, it usually takes 20 to 30 degrees rotation, mechanical rotation to get us to a 4-chamber view. So if it takes 20 to 30 degrees to get you to a 4-chamber view, then all the subsequent views are going to be 20 to 30 degrees higher than you would otherwise have gotten if you started at 0. And that just makes common sense. So don't be afraid to get a 3-chamber view at 160 degrees if that's where it is. I mean, it's just that patient happens to be a little rotated in relation to where the probe happens to sit. Okay. All right. So one other tip for you, because when you have a bioprosthetic valve, you don't have the asymmetric leaflets that tell you where the anterior leaflet is and the posterior leaflet is. So now you got to either have enough surrounding anatomy not to get confused, which is the best way to do it, right? So you look for left atrial appendage, you know that that's lateral. You look for aorta, you know that that should be, in a surgical view, anterior. But the other trick is that in most patients, and again, this is not going to be true if you have a very rotated patient, this little indicator, mechanical degree indicator, actually helps you. So it turns out that the mechanical degree indicator is pointed in this direction, and it turns out that it roughly correlates with where the aorta is going to be. So let's try it again. Let's go to 60 degrees. Yep, there it is at 60 degrees. What about 90 degrees? Yep, there it is again. It's at 90 degrees. So it's just the way that the probe is in relation to where the aorta is, that you will continuously be able to tell, or at least have some general idea based on the mechanical angle of the rotation. So let's try one last one at 160 degrees. Sure enough, there it is at 160 degrees. And remember that to get it to the surgical view, you just have to rotate it so that you know what's on top, where that the aorta is on top. And therefore, when you have a bioprosthetic valve and you're looking to see where the paravalvular leak is, you're not going to be confused. You're not going to tell your interventionalist it's on the lateral side when it's really on the medial side, or it's at 4 o'clock when it's really at 7 o'clock. Okay. Any other questions? So there's a really long question I'm going to try and read. Excellent. Mitral valve, uniformly axial. I'm wondering if there's a question. I may have to answer this. Okay, why isn't he performed well in advance of surgical intervention as well? I mean, I would have to say that most of our cases are, there is some kind of imaging, obviously, that has to document the severity of disease before our surgeons will take them to intervention. And certainly if the surgical intervention is a repair, none of our surgeons that I know of have not requested a TEE in order for them to plan whether or not they can repair. So remember that particularly in an asymptomatic patient, you can take those patients for intervention if the probability of an adequate repair is 90%. And you won't know if the probability for an adequate repair is 90% unless you do the imaging ahead of time. So we do it ahead of time. You may want to talk to your surgeons. It's well in advance of surgery. We don't tend to do it right on the table. The only time that we tend to be called up to the OR is when there's a discordance between the pre-procedural imaging and the operating room images. And you have to really, really, really be careful there, because obviously the patients are under general anesthesia. And that's when we'll start to ask for some hemodynamic loads, to mimic the loading condition in an awake state in order to more accurately assess the regurgitation. So just be a little bit careful there if you're asked to come up, because there's now only moderate mitral regurgitation under general anesthesia, because in all likelihood it's severe when they wake up, or it may be moderate when they're asleep and it's severe when they get up and run around. This is just a manuscript that I thought I'd throw in here that helps with the morphology of the anatomically appropriate patients. And the Heart Valve Collaboratory is a group of multiple stakeholders, including FDA, that have come together and are actually generating documents also. They've already published their red zone, which is the patients that probably should not be considered for a transcatheter edge-to-edge repair. Now, that does not include patients who you might consider for a transcatheter mitral valve replacement or annular device, but only the transcatheter edge-to-edge repair device. And then the yellow zone manuscript is almost written and submitted. So those are all coming forward. In the European guidelines, they also give you all the data with the predictors of MR with the annular repair. And so these are some of the things that we measure, and the justification for it is actually really nicely written in those guidelines. And the most recent study that's come out is a meta-analysis of various studies looking at predictors of success for TEER devices. And I recommend this highly. This is a beautiful meta-analysis looking at not only structural predictors, but also clinical predictors. Now, transgastric view for mitral regurgitation, I mean, it used to be one of those views that we relied on heavily relied on for the TEER devices because we didn't have three-dimensional imaging. But in 2007, when we finally got clinically available three-dimensional TEE probes, I mean, we just no longer ever went into the transgastrics for the TEER devices. But transgastric views are really, really helpful for a couple reasons. One, you can really see the chordal attachments super well. And the complexity of the chordal attachments. It also becomes really important, not just for the TEER devices, but the location of the papillae muscles and how high they are may impact some of the new devices that are being developed as far as implantation. So it's a good idea to look in the transgastrics, give us a nice short axis and long axis biplane view, allow us to see the chordal attachments and their complexity. But in addition, a number of our patients have commissural flails. And so this is an example of a P3 flail. So this is a medial leaflet flail. And the only location that we could align the Doppler with the regurgitant jet was a transgastric view. And so now you're doing all of your hemodynamics from the transgastric view. So please don't forget that transgastric can be your friend, and that you should go ahead and, particularly in the setting of eccentric jets, to go ahead and look in the transgastric to get your Dopplers. And then you've seen this already before, but you want to get your stroke volumes, either RVOT or LV alpha track. Okay, and that's really, I'm kind of at the end of the hour. I've got 4 more minutes. This is just the end slide and the summary slide, remembering to go ahead and download your PDF. It's 76 pages, so you might not want to print it, but to go ahead and download that onto your computers and you have it handy. We will hopefully be generating posters. I'm not sure, I haven't really discussed that with anyone yet, but and maybe flip charts to make it a little bit easier for people to access the data. But it is, as I said, really meant to be used in any number of ways, and hopefully helpful, particularly for those trainees as well as physicians that are out of training that have now are now dealing with being one of the earliest members of the heart team for these structural device therapies. Thanks for your attention.
All right, so that is all the time that we have today. So I want to thank Dr. Hahn for speaking and giving such a wonderful presentation. So for any unanswered questions, a Q&A handout will be made available when the recorded webinar is posted on the ASC Learning Hub. And thank you everyone for coming today. And once the webinar is over, you're going to be redirected to the CME request survey where you can claim your CME credits. So please don't exit the browser. And also make sure you join us for part 2 of this series entitled Guidelines and Review of Tricuspid Valve and Other Structural Imaging. This webinar is on Friday, December 17th from 2:30 to 3:30 p.m. Eastern Standard Time. So an email will be sent out with the registration link, or you can visit the ASC Learning Hub by selecting the link that I posted in the chat. So thank you everyone for attending, and I hope you have a great afternoon.